Okay, so welcome everyone to the first Seminal Six series presentation for 2026, hosted by August. My name is Matt Harris. I am a general surgery trainee up in the northwest of England and the bariatric lead for the RU group. It's my pleasure to be chairing this evening's webinar where we have one of the leading bariatric surgeons in the UK talking to us about evidence in bariatric surgery. Before we begin, I just had a very quick announcement about the RU educational meeting, which will be taking place on the 5th and 6th of May in 2026. So as a save the date for the diary, please do put that in your diary and keep an eye out for registrations coming out soon. So this webinar will be recorded and should be available afterwards. And please do ask questions using the Q&A function throughout this talk. And there should be around 15 minutes available at the end of this webinar to have a good discussion with Mr. Pournaras. So we have 45 minutes this evening, and it's my pleasure now to hand over to Mr. Pournaras, who is a consultant bariatric surgeon at North Bristol NHS Trust, and is a real expert. And it's my pleasure today to hand it over to you. So thank you for being here.
Thank you, Matt, and thank you to August for allowing me to be part of this very exciting series of the Seminal Six, the papers that really give us the evidence to practice our specialty, and I'm going to be focusing on bariatric surgery. This is North Bristol NHS Trust, Southmid Hospital. We took a picture on the one sunny day of the year. Please come and visit and reach out to discuss more about bariatric surgery. What I'll do is I'll be telling you the story, if you like, of bariatric surgery through those 6 papers, why we do it, how does it work, what's the effect in diabetes, and what is the latest clinical trials in the field. And I'll try to give you an anecdote on each one of those papers, the sort of stuff that you won't see in the paper. Those papers are easy to find. This is my conflict of interest. I work with a variety of organizations in the space of obesity. It's a complex condition, therefore we need a variety of interventions, surgery, devices, endoscopy, pharmacotherapy. But perhaps the most important conflict of interest I have is that I am a full-time NHS surgeon. I do bariatric surgery, I do upper GI surgery, I also do emergency and major trauma surgery, and I see obesity outside the obesity clinic. And perhaps the other important aspects of my conflict of interest I should declare is that 18 years ago, I did a PhD on a rather obscure at the time, a relatively unknown molecule called GLP-1. I now read about this in the national news, but that work and the fact that I was involved in that work has affected some of my views and the papers I'll be presenting today. So the first study I'll describe is the Swedish obese subject study. So this is the study that changed the field. It changed the way we observe obesity, the way we treat obesity. It's changed the researchers. It puts Sahlgrenska University in Gothenburg in the map of the academic centers of excellence, having an impact which is globally really important now. We would not be using this term today, obese subjects. People are not defined by the disease of obesity. They have the disease of obesity. And of course, some of those people would not be considered obese. They do have a normal BMI in the same way that a lot of us may not be hypertensive right now. We may be normotensive, but if we take a tablet for hypertension, we still have the disease. You can say the same thing about depression. So this is the study that they tried to do last Ostrom back in the 1980s, trying to do a randomized clinical trial of bariatric surgery versus best medical treatment at the time. He did not get ethical approval because surgery was considered to be too dangerous at the time. The mortality rate was about 3%. And now I want you to think, what do you think is the mortality rate, the 30-day mortality rate of bariatric surgery today? I'll tell you that it's 5 times lower than the mortality rate of a cholecystectomy. So right now in the UK, the mortality rate is 0.03%. And if you look actually at data from the bariatric surgery registry, and if you look at the audit that a lot of you have done as trainees about 10 years ago, it was 0.15%. So it's one of the safest operations we can do. But at the time, he was not allowed to do it. Most of us, and that's an important story in terms of academic journeys, would have given up by then, but he didn't. She did the second best, which was a prospective cohort control study. And again, most of us would have taken some patients that have bariatric surgery and we would match them for age, sex, BMI. But they went beyond that. They matched them for personality traits, for their hobbies, for personality characteristics. It's quite a phenomenal study. 4,000 people, again, to more detail. In 2004, they reported for the first time the weight loss outcomes. And it's not the weight loss that matters, it's the weight loss maintenance. As you know, if we all get ourselves locked in the room for 3 weeks or for 3 months for that matter, and we just get a pint of milk so that we can maintain life, we will lose weight, but we will put the weight back on when we get out. It was the maintenance of weight loss that they were able to demonstrate. Best medical treatment, 1.6% weight increase, and that's what you would expect. Most of us living with obesity will increase our weight and our BMI over the next decade. 1.6% is actually the effect of treatment. Gastric banding, VBG is vertical banded gastroplasty, an operation that it's not that I haven't done, but the people who train me have not done. Generations of surgeons now have not done in Europe or anywhere in the world. But we have converted quite a few of, I've seen, and I've converted quite a few of vertical banded gastroplasties into wide gastric bypass. But this was an intention to treat analysis. So people who were recorded as having a vertical banded gastroplasty at the beginning of the study, they still maintain in that position in that group, even though they may have a gastric bypass now. And you can see wide gastric bypass, 25% weight loss. This was the first time that it was demonstrated that for people living with obesity, for people with a BMI over 40 at the time, bariatric surgery is the only effective treatment option for weight loss maintenance in the long term at the time. Remember, it was the time before effective, the new generation of obesity pharmacotherapy. An absolutely phenomenal study. So we now have the 20-year data and the 30-year data, and this is a heat map, and the surgical groups have been grouped together, and you can see that maintenance of the reduction in body mass index. But we are not in the space of making people thinner. We're not in, I always say I'm not a weight loss surgeon, I'm a health gain surgeon. We're here to make people live longer. And the study was powered to detect a survival benefit. So 4,000 patients, 2,000 people on each arm, and the dotted line is a control group, the continuous line, the surgical group. At 13 and a half years, they were able to demonstrate survival benefit. There was a reduction in mortality or there was a lower mortality, to be precise, in the people who had a bariatric procedure versus the ones who were not. The loss at follow-up was 3, not 3%. 3 people were not followed up. And the way this happens is that everyone who is born in Sweden gets a number, which is not for research purposes. It's not to make the life of trial centers easier or researchers' lives easier. It's for taxation purposes. But they're able to find everyone. They call the embassies all over the world, people who emigrated, and find out if they were dead or alive. And they were able to tell us what is the difference between mortality between bariatric surgery and best medical treatment at the time. And of course, everyone would expect that this was driven by cardiovascular mortality, so reducing the risk of heart attacks, reducing strokes, but actually it was cancer-specific mortality. And we now have data from further reports of these studies reported multiple times in high-impact journals. The driving force is a cancer-specific mortality reduction in people who underwent bariatric surgery. Now, my anecdote is that I asked Lars Ostrom what happened to these 3 people. And Lars Ostrom played a key role in my career at some crossroads in my life. And I had the opportunity to ask him a question. And he told me that one of those 3 people went to a witness protection scheme, and the other 2 asked for the records to be deleted. They withdrew consent. They would still be able to find them if they hadn't withdrawn consent from the study. An absolutely remarkable study. Now, in the same issue of the New England Journal of Medicine. It was the summer of 2007. I remember it very clearly because I was starting my PhD at the time. There was a back-to-back paper from Utah, and this is the study by Ted Adams and his group. Six surgeons in Utah. They did almost 8,000 worldwide gastric bypasses. Most of them were open. They were in the open era, a bit like the Swedish obese subject study, the SOS study. The vast majority of those patients had open surgery. Towards the end, they were performing laparoscopic surgery. So what they did is they matched those 7,925 people with people who had similar or identical age, sex, and BMI from the driving license records in the state. So people living in the same state, they were applying for driving license. They had this information and they matched them, and they saw the mortality rate over a 7-year period. And you'll see that the people in the surgical group have a lower mortality. But what's really fascinating is seeing what is the mortality in the first year. And you can see that it's about 0.5%. And at the time, the idea was, remember, the other time the mortality rate had a wide range. 1.5% was considered at the time acceptable. Getting a mortality rate to 0.5% means that the risk of surgery is lower than the risk of not having surgery. And of course, now the mortality rate, as I said, is less than 10 times lower than that. So a very important message for all of us. And it's also confirmed the data. Those two papers back to back in the New England Journal of Medicine at the time confirmed that for the first time that reducing BMI saves lives. Until 2007, we would tell people that losing weight is good for you. We knew that people with a high BMI had a high chance of an early death, but we didn't know if this was reversible. We didn't know that if you were able to lose weight and maintain that weight loss, if that would have an impact on survival. And this is the first time that this was demonstrated in a non-randomized clinical trial. There is still, well, until recently, there was no randomized clinical trial data on that we now have from pharmacotherapy. My anecdote about the Utah study is that, and we've known this from Ted Adams and Richard Wellman, one of my mentors, has sort of corroborated this story, is that in one of those patients that was operated, went to stay in a hotel, which was quite a common, this is before the era of hospital or home, of course, but in the US, people traveling from far, they would often stay for a few days in a hotel after the operation. So one of those patients operated, staying in the hotel a few nights after surgery, was sitting there, and very unfortunately, in the room next to them, someone shot someone else. But the bullet went through the wall and killed the patient. It's really unfortunate. That is included in the mortality rate of surgery, because the way the analysis was done, it was still considered a death within a year after surgery, although clearly this was an unfortunate event, unlikely to be related to surgery. I'll now move to a study about how gastric bypass surgery work and why is this relevant and why is this important? Well, I think it's important for a variety of reasons. First of all, we need to know how the operations would do work. And I strongly believe that it's the duty of a surgeon, the duty of a clinician to know how our interventions work, particularly if the data are there. I also think it's important for those of us who did not do bariatric surgery because the anatomy you see here is not dissimilar to the anatomy of someone who has a gastrectomy for cancer and a wrong wire reconstruction. And indeed, when I hear, and I trained in esophageal gastric cancer, I don't do resections anymore, but I've looked after enough patients to tell you that what I tell and what my dietitians tell the patients after bariatric surgery is polar opposite to what we say after esophagectomy. But actually, what's happening is exactly the same. People tell us that they don't feel hungry. And we tell them that's because you have no stomach. But that's not true. And I'll show you the data confirming that that's not true. And also, the reason we all feel full is not because our stomach is about to explode. It's a time of the night that I hope most of you will be having dinner very soon. And if you've had it, that's fantastic. At some point, you stop eating and you say you're full. That's the words you use. But if I bring you your favorite drink, whatever that is at this time of the day or night, you will drink it and your stomach will not explode. The reason you feel full is because there's a message from your gut to your brain that tells you feel full. And this is driven by gut hormones. So understanding that is key from a clinical point of view in all types of upper GI surgery. But I also think it's important to understand. You all know what GLP-1 does now. You all know what how the pharmacotherapy of obesity has been revolutionary. Some people claim that's one of the most important discoveries in healthcare in the last couple of decades. This was driven by surgeons and researchers in this country identifying the role of GLP-1 and using the gut as a target for obesity care. And the people who have made the pharmacological discoveries and made it happen, the whole idea of being able to give GLP-1 receptor agonists to people, pharmacologically sort of enabling the treatment, the clinical treatment of millions of people around the world, were based on the findings from, again, research in the UK that bariatric surgery works via GLP-1. And I'll show you one of their studies. There's a number of them. Most of the work happened in the Hammersmith and Imperial College London and in University College London, with some work in between a collaborative around the country. So this is work that I'm not a co-author of this paper. I think that's important to say. But colleagues of mine are Alan Osborne, my colleague in Bristol, and Kyle LaRue, my PhD supervisor, and Richard Welburn, my clinical supervisor at the time. Did this study in Taunton in the southwest of England. Again, go back almost 20 years ago. Wide gastric bypass laparoscopically. It was a new operation. Most people will stay in for a week. It's now considered day case, a 23-hour stay for most of our patients. But in those days, people would stay for quite a few days, which allowed us to do a meal test. So we gave them a standard meal test, but they gave them a standard meal test before surgery and after surgery. You can see the hunger beforehand, and you see the satiety that's increased as early as day 2 and is sustained over a 6-week period. What they did next, what they did at the time, exactly the same time of the meal test, is they collected serum at different time points over 3 hours of a meal, and they measured PYY and GLP-1, and they measured the area under the curve. They measured the postprandial response. How much GLP-1 did you produce over a 3-hour period? And you can see that that's increased. If you measure fasting PYY and GLP-1, you won't see an increase, but if you measure the postprandial response, you'll see that there is an increase, a substantial increase, statistically significant, of course, as early as day 2, and is maintained over a 6-week period. So what I've showed you is an association between satiety gut hormones. These two hormones, PYY and GLP-1, are the two most profound satiety gut hormones we all have. This is the reason why we all stop eating our last meal. And I saw an association with an increase of those and increased satiety. But that's not causation. Although you could argue that you could probably get away with it in a surgical journal back in 2007, that is not causation. That is an association. What I'm going to show you next as part of the same paper is going to demonstrate causation. So what they did next is they took people who were weight stable and they did a double-blind study. So one day they gave them placebo, which was normal saline, and that's the yellow day. And on the red day, they gave them octreotide, which suppresses the whole endocrine response, and of course suppresses PYY and GLP-1 as measured here. Remember, patients do not know what they're getting, and the researchers do not know what they're giving. So what they did is that they offered them an NHS buffered kind of food, and I appreciate that's not the most amazing food, but they were all starved and they could eat as much as they would like, and they measured how much they ate and how full they felt. And you can see that on the red day, you have an increase in food intake and you have a reduction in satiety. And that demonstrates causation. If you reverse the gut hormone response, bariatric surgery doesn't work. And if you turn this around into cancer, if you give people octreotide, people who are struggling to gain the weight after an esophagectomy, after a gastrectomy, they will feel more hungry and they will feel less full. They will be able to eat more, demonstrating that what we do with bariatric surgery and cancer surgery is we change the anatomy and therefore we change the physiology. And via that, by modulating the gut hormone response, we change satiety, we change behavior. And that's one of the take-home messages of this talk today, that the mechanism of surgery, and we need to say this for both resectional surgery and bariatric surgery, is via the gut hormone response. And these are the most important gut hormones we know now. Of course, there are the mechanisms. They don't tell the full story, but they're the ones we know very well. And of course, we couldn't have predicted that GLP-1 was going to be the one that it's easier to pharmacologically target. So at the time, I thought PYY had a better chance, but it just shows how little I know in general. So my next paper is titled "Who Would Have Thought It?" It's by Walter Porras, and you can see the full title at the bottom of the screen. It's in red letters. Who would have thought it? An operation proves to be the most effective therapy for adult onset diabetes mellitus. And of course, the terminology used is back in 1995. And this is type 2 diabetes we're talking about. So this was a single center. It was a retrospective cohort of adults living with obesity and with type 2 diabetes. And the follow up was about 15 years. And they lost at follow up after 15 years. Remember, this is not a clinical trial, was less than 3%. So again, extraordinary. And the reason for that is that Walter Porras himself offered amazing care to those patients. And he looked after them beyond surgery, not just beyond bariatric surgery, beyond surgery. He became their personal physician in an underserved population. So people kept coming to see him, and he was able to collect that data and tell the world about the outcomes from a type 2 diabetes point of view. And you can see here they're using non-insulin dependence as type 2 diabetes people not being on insulin. And you can see 121 of those 146 patients have a normal glucose, normal A1C, and a normal insulin at about average 15 years after surgery, which is again extraordinary. And it was able to demonstrate that those changes happen before significant weight loss occurs. And if you look at people who were not people with impaired glucose tolerance, their metabolism, the glucose metabolism profiles were almost normal for the vast majority of patients. So these really challenged our dogma and our thought process. It made us think as type 2 diabetes as a disease that can be reversed. And of course, it's not correct. It cannot be reversed. And what we understand now, 30 years down the line, is that we can treat it so effectively that it can go into remission for a period of time. And if you wait for long enough, diabetes will recur, because by the time type 2 diabetes gets diagnosed, half of the beta cell function is gone already. So you can improve things, but it's challenged how we think of type 2 diabetes. It's challenged how we think of bariatric surgery and the whole concept of metabolic surgery, doing bariatric surgery, doing gastrointestinal surgery for type 2 diabetes became a new specialty. And a lot of us end up doing work in this field thanks to Walter Porras, who's still around in his late 90s. And you'll see him in conferences. And if you ever do, and this is my anecdote, you never sit opposite him. Everyone races to sit next to him. And the reason for that is not just because he has amazing stories to tell you the whole field of bariatric surgery, is because he cannot stop drawing. He cartoons people. And of course, if you're opposite him, you're going to see a cartoon of yourself in a future slide. So this is one of the slides that he said with the world, and a lot of us have used them. I particularly use them when I speak to diabetology conferences, and I've spent a lot of my time doing that in the last 15 years. He's a very well-established cartoonist and a wonderful individual. So I'll move to my next paper, and that's a series of papers at the time that started comparing surgery with medications in randomized clinical trials. I'm just going to talk about one of them, and this is by Geltrude Migrone, who's a professor in Rome, but has also spent a lot of time at King's College Hospital in London, together with Francesco Rubino, who again was in Rome at the time, but is currently at King's. And all of those patients were operated in Italy. It was a small clinical trial, as you can see, less than 60 patients, best medical therapy, raw gastric bypass, or biliary pancreatic diversion in people living with type 2 diabetes. And this is the 5-year outcome. It was in the Lancet a decade ago. And biliary pancreatic diversion is an operation most of us would not see in the UK. Most of us did not perform in the UK. It is considered the Rolls-Royce of bariatric surgery for type 2 diabetes. It has almost a mechanical effect on type 2 diabetes. Insulin resistance improves dramatically, But a bit like Rolls-Royce, you don't see many of them around. It's because the complication rate is really high. The nutritional complication rate, severe, that's severe nutritional complications, is about 8%. Therefore, most of us do not do this procedure, and I think even Nicholas Scopinaro's unit, who started this operation, a lot of people know this procedure as the Scopinaro procedure. So even in his unit, when people looked at 30-year data, the complication rate is just unacceptably high, and people have stopped doing it. But what we have seen is that in this study is that with bypass or BPD, there was a reduction in cardiovascular risk. Again, focusing on the life-saving aspect of surgery. This is not about kilos. There was a reduction in cardiovascular risk in this randomized clinical trial. But if you look at the 5-year data, not a single patient was in complete remission of type 2 diabetes if you use strict criteria. And that is because type 2 diabetes is a chronic and relapsing condition, and therefore we need to treat it better, and we need to give medications a bit like we do for all other conditions. We don't do chemotherapy versus surgery. I would argue, and I've asked ChatGPT today just to confirm my bias, that the most important clinical trial in the field of esophagogastric surgery is the MAGIC trial, is the perioperative chemotherapy, still is, 30 years down the line, perioperative chemotherapy for cancer. We don't talk about, let's just do a trial of surgery versus chemotherapy. In fact, the field has moved on and we're looking into different combinations of different modalities, and that's what we need to do for bariatric surgery. So this is not a seminal paper, but this was an editorial at the Lancet for exactly this paper that Carla Rue and myself wrote. And we didn't recognize it at the time. We just wanted to make a point that we need to combine those modalities, but we used multimodal treatment for obesity and type 2 diabetes, which we thought was the standard of care, as it is the standard of care for cancer surgery. And I remember very well, as a cancer resectionist, at the time working in the cancer unit as a registrar. Turns out that it has not been used before, so now it's becoming finally the standard of care in bariatric surgery. We now have European conferences being titled as multimodal treatment conferences. So we are moving towards that direction, not fast enough, perhaps, in my opinion. And finally, I have to talk about the world's largest randomized clinical trial in the field of bariatric surgery. It's only a coincidence that it started in the University of Bristol, which is where I'm based. But it was a study led by Professor Jane Blaseby and Professor Richard Welburn, Professor Jim Byrne, and units around the country, 13 units around the country, 1,300 people started in, and I remember the day the study it was decided this people were going to go ahead with the study, and hands were shaken in Bristol about 15 years ago. And it started as bi-band, so comparing gastric bypass with gastric banding. And now I remember thinking that this is hopeless. This is never going to work. And the vast majority of people thought that there's no way this study will ever work. And there we are. The study did evolve, and sleeve gastrectomy became a very common bariatric procedure. And the study was adapted to the bi-band sleeve. And we now have the 3-year outcomes, a 3-year endpoints, and gastric bypass, which is Roux-en-Y gastric bypass, is better than sleeve gastrectomy and gastric banding. And both gastric bypass and sleeve gastrectomy are better than gastric banding in terms of weight loss and with equivalent quality of life outcomes. And of course, you could read those in the paper published in Lancet Diabetes Endocrinology. But the key message of this paper, if you like, is that randomized clinical trials are hard work. They can still happen if 13 units around the country get together and do a study that everyone thinks that it's impossible to do. So I will conclude by saying that I've taken through a tour, if you like, of 6 seminal papers in the field of bariatric surgery. The message for any lecture or any talk in bariatric surgery should be that we need to treat obesity as a disease. We need to stop debating if it is or not. I definitely have a long time ago. We need to treat it as such. We need a multimodal care approach, as we do for all other conditions in the field of healthcare in general, not just in gastrointestinal surgery. And we have to remember that things are moving fast and the pace of change is very fast. And this is the last flying of a cockroach Concorde ever on this planet. It just flies over the Clifton Bridge, which is just around the corner from where I'm based at the moment. It's in Bristol, and you'll see a lot of people are out there waving at it because a lot of the engineering happened here in Bristol. So if you ever visit us, you can always visit the museum where the Concorde is. And the point I'm trying to make is that the world has become a smaller place since we lost the ability to fly supersonically. But the pace of change, although it has never been this fast, it will never be this slow again. 18 years or 20 years, the range of studies I've showed you today is around 20 years, and you've seen a rapid change. I can't be certain about what the future holds, but I'm certain that the pace of change will be a lot quicker in the next 20 years. Thank you for listening. This is my colleagues in North Bristol and collaborators in Dublin in Sweden and in Imperial College London. And I'm going to finish with this bit of modern art from Damien Hirst. Two different works of art, surgical instruments, pharmacotherapy. We need both if we're going to treat any disease successfully. Thank you very much. It'd be nice to have a discussion now with some questions and answers.
Thank you so much, Mr. Pournaras, for your excellent and really insightful presentation. Again, I would like to invite any questions from the audience using the Q&A panel whilst these are coming in. I have loads, and we'll make good use of the next 10 minutes or so, if that's all right with you. Um, I come from a bit of a biased background. I'm really interested in some of the mechanisms between how the treatment of obesity can treat obesity-related complications. You mentioned, especially in some of the mid papers, the Carol LaRue papers around the physiology. So I was interested to hear your insights around the mechanisms by which bariatric surgery can affect disease endpoints like type 2 diabetes or even something like cancer or mortality. Is that driven by reducing the fat, or is there other mechanisms inherent to bariatric surgery itself?
No, thank you. That's a great question. I spent a big part of my life actually explaining the and demonstrating the impact, the weight loss independent effect of bariatric surgery on glucose metabolism and on type 2 diabetes. So, of course, we know, and we know this from physiology textbooks in medical school, that if you lose weight, your insulin resistance will go down. And I didn't show you that because this is not seminal papers, this is just a bit of my work. But if you measure insulin resistance day two after gastric bypass, it reduced dramatically. Now, some of it is starvation. So if you put people into a very low energy diet, the liver shrinking diet, as we call it in bariatric surgery, so less than 1,000 calories for 2 weeks. So within 6 days, your liver volume is reduced by 25%. You just have a quarter of your liver is gone. So if you're doing a lap collies, please do that. It's my waiting list coordinator gives this information. You don't need a dietitian, and it's great. But at the same time, you reduce insulin resistance. And again, I've tested this in a randomized clinical trial when I was at the Karolinska. And the effect in the first 2 weeks, the effect of starvation, an effect of this diet is the same as the effects of a gastric bypass if you measure total body insulin sensitivity. If you measure hepatic insulin sensitivity, which is slightly different, then bariatric surgery really has a profound effect. The key home message, if you like, is that there are weight loss independent effects and they're profound. A year or two down the line, weight loss is dominant. And then you have other aspects of it, which is the reduction or the paradoxical increase in energy expenditure. So energy expenditure when we all go on a diet goes down, and this is the reason why we all struggle. So if we start a diet at the beginning of the year, this is a really good time to talk about this. The first week of January is okay. The second week you continue to lose weight, but it slows down. But third, fourth week, the weight loss has decreased, and we convince ourselves we're not motivated enough. But that's not true. It's just reduction of energy expenditure. In bariatric surgery, that goes up, and we know this from animal models. So you can see all of those effects have an impact in insulin metabolism. I think for cancer, a key driver is reduction of insulin resistance, therefore reduction of insulin levels. High insulin levels are really bad for you, really bad for cancer, really, really toxic. really bad from a metabolism point of view. So I think that is what's driving things. Now you also have the clinical aspects, which is that if you're smaller, it's easier to pick up a lump and you feel, oh, I'm feeling something, I'll go to my doctor. It's easier to feel healthier. And the bias or that people face when they live with obesity, we know that they have worse outcomes because people say, oh, I have a headache. Oh, what do you expect? You have obesity. So they don't get the same, they don't get the CT head, and we miss the cancer, we miss the clinical diagnosis there. So all of those together is multifactorial, create the perfect storm. And bariatric surgery or effective obesity care solves it. I gave you a long answer, but I hope that was of some interest.
No, it's a great answer, and I think following on from talking about the weight independent effects of bariatric surgery, I thought it'd be interesting to have your take on managing weight regain, and all of the different, ways to manage that and complexities.
So first of all, so we're changing our terminology around it, and we talk about recurrent weight gain, which is more precise and less stigmatizing in the field of bariatric surgery. But absolutely, recurrent weight gain is an issue. So and if you look at the news in the last few days, there's all this surprise that people who stop being treated for their obesity with pharmacotherapy, the medication stops working. I mean, you wouldn't say this for an antihypertensive. You wouldn't expect the inhalers if you have asthma to continue working after you stop taking them, and you wouldn't expect the statin to have an impact 6 months after you stop taking it. But for some reason, we expect treatment for obesity to continue working, which just shows that we're not treating obesity as a disease. So all effective treatments for obesity have fatigue with time, just like all treatments for chronic conditions fatigue with time. And biology, then there's two reasons for that. Biology and homeostasis gets used to it and their escape pathways, but also the evolution of the condition continues. So those of us who have a BMR 50 today, if we are left untreated, in 10 years, we will not have a BMR 50. We'll have a BMR 55 or 60. So if that 50 goes down to 35 with effective treatment, and then age 45 in 10 years, that is the effective treatment which we would expect. So I think the key aspect of it is understanding the biology. We seem to get it very well for other conditions. I mean, most people who get treated for hypertension, they expect the treatment to be escalated 10 years down the line, even if they're very compliant, because the condition changes. Most people with type 2 diabetes will have escalation of the treatment, adding either increasing the dosage of current medications or adding modalities down the line. So we need to think exactly the same way. We treat obesity as a fracture. It is a chronic condition and needs to be treated as such. And if we start doing that, everything, even the physiology, starts making a lot of sense.
Sure. And picking up again from something that you mentioned is about new GLP-1 drugs. And I wanted to ask you about, I guess, your use and what the current evidence or maturity of evidence there is around the use of GLP-1s in patients, either before a bariatric operation or after a bariatric operation.
So I'm an enthusiast. I think those medications are safe. We do know, as someone who's measured GLP-1 after gastric bypass, I can tell you that it goes sky high after gastric bypass. It also goes sky high after esophagectomy or the gastrectomy, but nobody seems to worry about that. And I think that the long-term outcomes are so far what we know, 5-year outcomes are great. We also know that we've manipulating GLP-1s for about 20 years. If you look at the first drug manipulating the GLP-1 axis, exenatide was licensed in 2006. So that's a long time ago, and a lot of people around the world have had it. So I think they're safe, and they're effective within limitations. So you need to continue taking them, just like any other disease, any other drug for chronic disease. We need to be careful of side effects. There needs to be some regulation around it. And I think that we need some more studies, and we're doing some randomized clinical trials on exactly that field for diabetes. I use oncological terms. So I talk about neoadjuvant treatment using GLP-1 based treatment before surgery. I talk about adjuvant. If in the context of breast cancer, we don't wait for the recurrence to happen before we start hormonal therapy. We start immediately the treatment, and then it's rescue pharmacotherapy or rescue chemotherapy, for recurrent disease. So we need the clinical trials. We don't have all the answers, but we do know, and again, in contrast to my bias at the time, and again, it could have been another clinical trial I could have put into there as a seminal paper, that in people with diabetes, and this is work done again in the UK by Alex Mirris in Imperial College London, if you give people GLP-1 receptor agonist after surgery, for diabetes, they do improve the diabetes and they get weight loss. Almost, it's well tolerated, and it's almost better than people who are bariatric surgery naive. In contrast to what I told Alex at the time, I thought this was going to be a negative study, and again, it shows how little I know, and it shows why we need to do clinical trials to get new insights. And UCL and Jessica Mox and Rachel Batham's unit have done this in people without diabetes with semaglutide, and again they demonstrated that. So it works. It's effective. We need to do more of it, but we need to have the set up for it, which right now in the UK we have probably a couple of million people on these medications. Very few of them are getting those medications in the NHS.
Sure, thank you. I probably have time for one more question, and this might be quite a hard one. And it comes from, again, my biased interests is around obesity management in people living with cancer for cancer prevention who have high risk of obesity-related cancer. So I wanted to ask, I guess, your thoughts and personal experience from that side.
Yes, absolutely. So, I mean, I have an odd clinical practice. I get referrals from some oncological units around the country for the most challenging conditions. I had just endometrial cancer, and I have done bariatric surgery in people, in women with endometrial cancer, and they were able to preserve their uterus, and some of them were able to go and have children. And I have I've prescribed GLP-1 receptor agonists, when in the sort of context that was allowed either in the NHS or outside the NHS to treat women very successfully. So it works. It's important that we do that. We need clinical trials to make this the standard of care. I think conditions such as endometrial cancer is a very attractive target because it's the only cancer I know that you can lead to resolution with effective obesity care. But more closely to what we do, colorectal cancer, I do think that we need more work on that. I don't think we have right now the evidence to make this a standard of care. And I think we have the evidence to give people with cancer obesity care based on the evidence on obesity. But what I'd like to see, and there is collaboration. I think some of this work will come from the UK. I'd like to be able to specify which patient has a high risk of cancer and treat them aggressively at a very low BMI, because BMI doesn't tell us anything about obesity risk. Whilst I perhaps do not need to treat someone else who has a low risk of cancer. We need multi-omic work on that, and we need clinical trials in this field. It's going to be very exciting. I hope
Yes.
I've answered the difficult question. I don't have all the answers, but I think it's going to be exciting. We need to do the study.
Hey, that's a great answer. Thank you so much. I think unfortunately that's all we have time for, but it's been a brilliant whirlwind 45 minutes, and I just wanted to say a huge thank you for your time and expertise for supporting our Seminal Six series. So thank you very much. And as a reminder to everybody that this recording will be available afterwards, I probably will be definitely reviewing this again. So thank you again, and
Thanks for
see you
having me.
all next time.